Mrs. Gardner. Hi, all my viewers. My name is Melanie Frechette, and I am currently studying Health Information Management. This PowerPoint is part of a Pathophysiology class assignment, so please refer to the references at the end of the presentation or other pathophysiology sources for information not covered in my presentation. Ovarian cancer is the leading cause of gynecologic cancer mortality. It's also the fifth leading cause of cancer death among women. Although we don't fully understand how one develops ovarian cancer, studies have shown that there are some risks. These risks include being a woman over 40, having a history of ovarian or breast cancer, and having non-polyposis colon cancer. Studies have also suggested that certain conditions, such as genetic predisposition for these types of cancers, benign inflammatory diseases, other cancerous lesions present in the body, and endometriosis can all play in developing ovarian lesions. Statistics have shown that some women of certain ethnicity, especially those of Japanese and Swedish women who have ovarian endometriosis, do have a slightly higher risk of developing these malignant lesions. It's shown that patients who have a high number of BRCA1 or 2 gene mutations may develop atypical epithelial cells in the distal fallopian tubes, and thereby it does affect the ovaries. 18% of patients with ovarian cancer do have a pathogenic germline mutation of a cancer susceptibility gene, and 83% of these are the BRCA1 or 2 genes, and they're seen in about 10% of all patients with ovarian cancers. Another popular cancer susceptibility gene that is found in some patients with ovarian lesions is the CA125. Unfortunately, studies have also shown increased risk of developing ovarian lesions in patients that are undergoing estrogen or other hormonal therapy. The most common types of ovarian cancers belong to surface epithelial stromal tumors. These tumors are easily differentiated by histological type. For example, we have a serous low-grade type. There's a serous high-grade type. There's mucinous epithelial stromal tumors, endometrioid and clear cell tumors, as well as the very rare transitional cell and squamous cell tumors. Germ cell tumors are another type of ovarian cancer and account for approximately 8% of all ovarian neoplasms. However, these tumors are quite interesting as they are known to create hormones such as estrogen and androgen. Ovarian cancer is known for metastasizing to other locations, but they do come from other locations as well. Up to 20% of them come from the digestive system, the genitourinary system, and the breasts. It's worth mentioning a few facts about ovarian cancer metastases. 30 to 40% of tumors are called Krukenberg tumors. They're metastases from the stomach. 7 to 10% of malignant ovarian tumors are most likely metastatic. Bilateral masses is a sign of secondary ovarian cancer, and most metastases are found by accident. Although signs and symptoms of ovarian cancer do not present until later stages in the disease, some patients do experience abdominal discomfort or bloating, constipation, lower back pain, irregular menstrual cycles, urinary frequency, and dyspareunia. Ascites, however, is one of the most common signs for ovarian cancer. A history of breast cancer may also be a precursor to ovarian cancer symptoms, such as abdominal pain, nausea, vomiting. In many cases, signs and symptoms are associated with secondary ovarian lesions in other parts of the body. When a patient has signs or symptoms of ovarian cancer, a physician may perform a bimanual pelvic examination and send the patient for a serum CA125 level assessment. Afterwards, the patient will be sent elsewhere for tumor imaging. This can be done with a CT scan, MRI, or an ultrasound. Ultrasonography does have its advantages. It's safe, budget-friendly, and non-invasive for the patient. new technology and ultrasounds can now offer an appreciable differential diagnosis. There are a few known ways that someone can prevent ovarian cancer. These include having a previous pregnancy, breastfeeding, tubal ligation, or salpingectomy, although there is a risk of breast cancer development with the use of oral contraceptives. Prolonged use has shown the decrease in developing ovarian cancer. BRCA1 and 2 carriers do reduce their risk of developing ovarian cancer with prophylactic surgery such as an ovarectomy or mastectomy, as well as thorough screening. When it comes to treatments, the goal is to personalize medical care such that each patient receives the best treatment for her specific tumor burden, one that will provide her with the longest overall survival and the highest quality of life. Treatments may include conventional chemotherapy, cytoreductive or debulking surgery, neoadjuvant chemotherapy, platinum-based or combination platinum-based chemotherapy, and monotherapy with non-platinum agents. There are a few difficulties when dealing with ovarian cancer. First, it can be referred to as the silent killer. Ovarian cancer is commonly asymptomatic in early stages, and by the time a diagnosis is made, the prognosis is poor for the patient. With an incomplete collection or knowledge of the patient's family history, or when there is no personal or family history of ovarian or breast cancer, testing for ovarian cancer is often not assumed. Unfortunately, the lack of provider expertise in ovarian cancer or an absence of funding for obtaining counseling and testing for pathogenic genes are a reality. In sporadic cases, up to 90% of ovarian cancer patients are non-carriers of germline gene mutations. Unfortunately, most people do encounter relapses a few years later, and some do develop resistance to therapeutic drugs. There is only a 10% or a 10 to 30% survival rate for patients with relapses. Other complications are the ones affecting therapy choices, such as prior anti-cancer drugs, refractory disease, and other underlying medical problems. Therapy also comes with side effects and may cause adverse reactions in the body. In some cases, medical centers may have less experience in choosing the right type of surgery for the patient, and there may be limited capacity and access to genetic counseling for many people. Overall, the prognosis for ovarian cancer patients is very poor. Patients are too often diagnosed late, and relapses are very common with this cancer. In these cases, the patient and provider must work together to see if chemotherapy or palliation alone will suffice for the patient, as a cure is seldom the endpoint in many cases. On an ending note, I hope you have learned a little bit more about ovarian cancer. Thank you for attending this PowerPoint presentation.